Good afternoon, all. I am Julia Mandeville. I am one of the co-founders and the Public Health and Advocacy Manager of the Barbados Association of Endometriosis and P.C.O.S, otherwise known as polycystic ovarian syndrome in the US and polycystic ovary syndrome if you're coming from, the UK. And it's my honor to welcome you to this virtual panel discussion, Endometriosis, More Than a Reproductive Health Issue. And Dr. Daisley will speak more to our title in a bit. So I don't want to encroach on the information our much more knowledgeable and experienced panelists will share, but I just wanted to bring some facts and research of endometriosis to the fore because that is my passion. I'm a public health analyst, and I do a lot of public health research on the side. So endometriosis is defined as an inflammatory disease associated with pelvic pain and infertility that is characterized by lesions of endometrial-like tissue outside of the uterus. Severe endometriosis pain can affect quality of life, and research shows that there is an elevated risk relationship between endometriosis and the development of mental health disorders like anxiety and depression. Further to this, in 2013, it was determined that the estimated annual cost of endometriosis was US $12,419 per woman, comprising 1/3 of the direct healthcare costs and 2/3 attributed to loss of productivity. So I just want us to really think about these facts and look at the facts that are on the screen as we go through this panel discussion today. So knowing this, therefore, we strongly believe that care shouldn't just be focused on reproduction or fertility outcomes, but the overall health-related quality of life of those impacted. Thus, we at the BAEP are thrilled to host this panel discussion in collaboration with the University of the West Indies Cave Hill campus and have our exceptional moderators, Dr. Damien Best and Dr. Rashida Daisley, who will guide us through this session with our superb subject matter experts. The session is meant to provide a space for sharing and understanding. So to that end, we have to acknowledge the cultural and socioeconomic context, as well as our resource constraints that are unique to us in Barbados. However, it is also our hope that fora like this will allow for navigation of these barriers and increased understanding, effective collaboration, and a strengthening of the patient-practitioner relationship leading to better health outcomes. So again, thank you so much, and over to you, Dr. Daisley.
Thank you so much, Julia, for that lovely introduction. It was actually quite informative in itself. So good evening, everyone, and thank you for investing your Saturday evening with us. I'm not sure if you could be doing anything else given that we are still in lockdown technically, but still thank you so much for joining us. So as Julia said, my name is Dr. Rashida Daisley, and I'm the president of tonight's host organization, the Barbados Association of Endometriosis and Polycystic Ovarian Syndrome, and as well as your co-moderator for tonight. So tonight we have an amazing panel lined up to impart their knowledge on the topic of endometriosis, more than a reproductive issue. So we'll be discussing extrapelvic endometriosis in varied background from its presentation to diagnosis and its management, particularly in the Barbadian population. So before we dive into the panel's introductions, I'd like to give you a bit of background about BAEP, or BAEP. So the Barbados Association of Endometriosis and PCOS is a charity that was founded in 2016, which seeks to educate citizens and advocate for and provide tangible support for those who are afflicted with these conditions. Recently, we've actually added capacity building among healthcare professionals and allied professionals in diagnosing and or managing these conditions. So why extrapelvic endometriosis? So endometriosis remains one of the most enigmatic gynecological conditions, which is why us here at BAEP advocate for it so hard. And this is mainly due to the complexity from its diagnosis right down to the management. Much of the focus, rightly so, is placed on reproductive endometriosis. And that's because of its implications in terms of fertility. I'm aware that, we have a varied background in our audience. So when I say reproductive system, I'm talking about limited to like the ovaries as well as the fallopian tubes. However, it's still important that we widen the scope to increase the awareness on extrapelvic endometriosis, because this can still have significant impact on morbidity and in some cases mortality as well. So tonight, we do hope to have a very smooth session. So I'm just going to give you a brief outline about how the session is actually going to go. So first, myself and Dr. Bess will take a few moments to introduce the panelists. Then each panelist will be given 2 minutes just to give their brief detail of their experience with endometriosis in their respective specialties. Then we'll open the floor for a bit of Q&A for that particular panelist. And at the ending of the presentations, we'll open the floor for the audience to really interact with the panelists and ask some questions. That being said, I just want to make sure that when you're asking your questions in the Q&A section, that you make sure that you indicate who you're asking the question to, right? So let's dive right into the introductions. I'm not sure if Dr. Bess, you have anything to say before I go ahead?
Nothing more to add to what you said, Rashida. Thank you very much for introducing me. Just to say that the University of West Indies has come on as a supporter of this venture. And while we have a good complement of medical practitioners in, unfortunately, there's no CME credits on this occasion, but we do expect to have another event in the near future where you can get some credits. That said, everybody enjoy today's session. It's going to be great.
Next slide, please, Julia. Okay. So I'm going to start by introducing Dr. John Barker. So Dr. Barker is an obstetrician gynecologist consultant in the UK and is currently a consultant and director at JRB Medical Centre. He is currently an OSCE examiner at the University of Liverpool. He's also a member of the Royal College of Obstetricians and Gynecologists, a member of the British Society for Colposcopy and Cervical Pathology, and also an International Society of Sexuality and Cancer. He also formed the Endometriosis Center and is part of a multidisciplinary team designed to treat deep infiltrating endometriosis and develop a one-stop postmenopausal bleeding clinic. That's very interesting. He also has an outpatient hysteroscopic service and gynecological oncology diagnostic and triage service. His clinical interests include outpatient diagnostic and operative hysteroscopy, minimally invasive surgery, emergency gynecology, and high-risk obstetrics. His aim is to work with other professionals, to improve the level and standard of care for women by offering evidence-based medicine and a holistic approach to patient care. So thank you very much, Dr. Barker, for joining us today.
Thank you very much.
Our second panelist is going to be my good friend, Dr. Erica Springer-Cyrus. I should say that everybody here presenting is my good friend. So if you hear me say that over and over again, that's what it's all about. So Dr. Springer-Cyrus is a practicing Barbadian gastroenterologist. She is a graduate of the University of the West Indies, having done her MBBS, like many of us here at Cave Hill, and having attained her postgraduate training in internal medicine again at Cave Hill, followed by a fellowship in adult gastroenterology at McMaster University in Ontario. Currently, she's the head of the gastroenterology department at QEH, where she provides emergency and elective gastroenterological services for patients with GI bleeding, gastrointestinal bleeding, and for suspected cancers. She also is part of the internal medicine consultant team and assists with patients with a variety of medical ailments and conditions. And she also maintains a private practice where she manages patients with functional gastrointestinal disorders, inflammatory bowel disease, and liver problems. Thank you for joining us, Dr. Springer-Cyrus.
Next up, we have Dr. Persaud. So Dr. Persaud completed his Doctor of Medicine in Urology in 2015, and then completed 2 years of subspecialty training in endourology in the United Kingdom. He then returned to Trinidad in 2018 and is a consultant based at the San Fernando General Hospital. He's also a lecturer in urology at the University of the West Indies and a director of the residency program in urology at UE, where he trains local urologists. He's a fellow of the Caribbean College of Surgeons and the Royal College of Surgeons of England. He's also a member of the International Society of Urology and the American Urological Association. He served on programs for Developing World Committee, the Developing World Committee of the SIU Academy, and currently sits on the Endourology Committee of the SIU Academy. He's also the Vice President of the Caribbean Neurological Association and has authored numerous research papers in neurology. Welcome, Dr. Persaud.
So yes, welcome to my good friend, Dr. Persaud, affectionately known as Sati or Avinash. So next we also have my good friend, Dr. Sally Griffith, Philip to some of us, who I met at Mona, Block B, so he's a brother. So Dr. Sally Griffith is a general advanced laparoscopic and bariatric surgeon who is trained at the Center for the Advancement of Minimally Invasive Surgery in Alberta, Canada, also at the University of the West Indies, including Mona, and the Imperial College London, United Kingdom. In 2005, he became a member of the Royal College of Surgeons of Edinburgh. Since July 2011, Dr. Griffith has been practicing home in Barbados, where he's from, performing advanced laparoscopic and bariatric surgeries, and has been the medical director of Surgical Solutions, Inc. from that time. He later took a job as a consultant minimally invasive surgeon at the Queen Elizabeth Hospital from January 2014, and has also been appointed to our great university as an associate lecturer at the University of the West Indies, Cave Hill, in general surgery. Welcome, Dr. Sally Griffith.
And last but certainly not least, I'd like to welcome Dr. Best's good friend, I'm sure, Dr. Christita Paulette. So Dr. Paulette is a senior registrar at the Queen Elizabeth Hospital. She's completed her training at the University of West Indies Mona campus, and she's the only woman to have graduated the Doctor of Medicine program in cardiothoracic surgery. So I'd just like us to take a minute to just soak that in. Congratulations on that accolade, Dr. Paulette. She's completed a 2-year fellowship in cardiovascular surgery at the prestigious Texas Heart Institute in Houston, Texas, USA. Her professional interests include female cardiac and thoracic health and transcatheter valve therapies. She is currently an associate lecturer in surgery at the University of the West Indies Cave Hill campus, has published peer-reviewed articles, and is a co-author on the chapter of cardiovascular medicine texts. Outside of medicine, she enjoys gardening, baking, and reading. Welcome, Dr. Paulette, and thank you so much for joining us today.
Thank you, ma'am.
Thank you. So I think right now we're going to jump into the first presentation, which will be by Dr. John Barker, who's going to be talking a little bit about multidisciplinary approach to endometriosis management.
So you're going to give a short talk on endometriosis, pelvic and extrapelvic. We went through my introductions before. Right, now what is endometriosis? Essentially it's cells with the same morphology, which is the same likeness of the endometrial lining of the womb found outside the uterus. It usually occurs between 10 to 20% of women, and it can be asymptomatic or symptomatic. Usually is a major cause of chronic pelvic pain and infertility, and causes psychological issues, and it's commonly pelvic but can occur anywhere in the body. Excuse me. The importance is a major cause of fertility, is a major cause of chronic pelvic pain. It has a lot of psychological issues associated with it, and it has significant financial and social implications for the woman, the patient, and her family and friends and work. Now, how is it diagnosed? Usually by history examination and investigation. And in terms of the history, generally, patient will complain of lower abdominal pain, which is constant or intermittent, which is made worse around when her menses would be. And then it usually goes back to being dull in the background, either constant or intermittent after her menses have finished, You can also get painful menses, painful sex, which is dyspareunia. Very rarely they can complain of hematuria when urinating around the menses, and the same for when they're having a bowel motion at the time of the menses. Even rare still, you can get a lump around like cesarean section scars or at the umbilicus, which can appear at or around the time of the menses, or sometimes they can have no symptoms at all.
Thanks for this, John. Just before we move on, can I ask for you to just clarify the term hematuria for our guests who might not be medical?
Blood in the urine.
As well
Blood
as
in the urine.
Yeah.
necessary.
All right.
Right, thank you so much.
Now, in terms of the adolescent group, which would be the adolescents, their history will be the same as previously listed, and it's important not to dismiss them. And if they have any issues, then it's best for them to see an adolescent gynecologist. And the reason for this is that they are better specialized at dealing with the adolescent population. Now, in relation to symptoms of extrapelvic endometriosis, usually you will find a palpable mass, or sometimes you can get cyclical bleeding around cyclical bleeding of the mass. It can occur in anywhere in the human body, and essentially it is rare. There are only about 5,000 articles in relation to it, and the majority of cases are usually thoracic or in the abdomen. Now,
Okay, so that's in the chest and the abdomen.
yes, please.
You mentioned briefly the younger ones, the teenagers should see an adolescent gynecologist. Do we have one of those?
Yes, we do.
Okay, so why particularly an adolescent gynecologist as opposed to a general gynecologist, if you don't mind me asking?
The adolescent gynecologists will be specially trained in relation to history taking and seeing the patients either by themselves or with the parent. And at this time, usually mostly with the teenagers, sometimes they might be a bit guarded. And the adolescent pediatric gynecologist is better, in my opinion, in relation to dealing with this particular subset of patient.
That is fine. Thank you so much.
No problem. In relation to, hold on a second.
Someone here in the chat who's just making a point here in terms of acknowledging adolescents. Maybe either Dr. Barker or Dr. Best, you can tell us a little bit about your experience with adolescents presenting with endometriosis, because I do know sometimes, particularly very close to menarche, the pain can be quite severe. So what's your experience with persons actually with endometriosis in the adolescent age group?
I don't know if John is ready to take that one.
No, you can take that one. They still getting issues.
Sure. So I have had, I would confess and say, limited experience with seeing it in adolescents. I do see a lot more 20-something-year-olds, 30-something-year-olds with endometriosis. But having come to a few of your events, including walks and stuff, and having some conversations with some of the ladies in attendance, it would seem like it's probably more prevalent among teens than we realize, you know, because we've always been taught in medical school that the more cycles you have, I guess is that whole retrograde menstruation idea, the more cycles you have, the more likely you are to eventually get endometriosis. But to bring back to what I was saying about why it could be so far flung, and so there's this new theory, Mullerian embryological Mulleriasis theory, right? Which is suggesting, based on some, science, they've actually dissected some female fetuses and found that, similar to the adult population, 1 in 10 of those fetuses had some endometrial-like tissue outside of the pelvis, right? So it seems that somehow during the embryological development of females, 1 in 10 will develop endometrial-like tissue outside. And that would even explain why it can be sometimes possible to have it in boys, right? Obviously not gonna react the same way because it's not the same sort of hormonal cycle, but it kind of makes sense that that is the most plausible theory as to how it arises, since it can happen anywhere.
In terms of abdominal extrapelvic endometriosis, is divided into parietal and visceral. The parietal endometriosis are lesions primarily in the abdominal wall, groin, and perineum. So sometimes you might get a lump in the umbilicus, a lump in the perineum that gets bigger around your menses. So that's parietal endometriosis.
So that some of the guests might not be aware of these very large words.
Right. So essentially, the parietal endometriosis means that it is confined to the abdominal wall, to the surface, right? Whereas the visceral involvement would be your abdominal organs, right? So all the organs inside, all right? And then the thoracic endometriosis will be endometriosis confined to your chest, all right? And usually that will present with menses. Sometimes it can get, we call it pneumothorax, or sometimes it could be coughing up blood as well. You may see a deposit or a lump at the level at the scare or the belly button, which is the umbilicus, or on vaginal examination, you may have tenderness in the vaginal fornix, and essentially where this is where the vagina meets the cervix, right? And this is evidence of what we call uterosacral disease, which is disease in the ligaments that keeps the womb up, all right? You can also have a mass, which is an ovarian mass, and we call that an endometrioma.
Now, those are the kind of big chocolate cysts, yeah? Having some old blood and stuff.
We're going to come to that.
Okay.
Now, in relation to the differential diagnosis, because everything has a differential diagnosis, the major differential diagnosis would be pelvic adhesions, irritable bowel syndrome, interstitial cystitis, which is essentially just minute bleeding in the bladder, but I'll let the urologist deal with that. And the next one would be adenomyosis, which is essentially the lining of the womb growing in the muscle of the womb. So every time you have your period, you will get painful, heavy bleeding. So those would be your main differential diagnosis. Now, in relation to the diagnosis, for the investigation, sorry, there'll be transvaginal scan. Now, this ultrasound on your left, where you see this round structure and the dotted line, that's the endometrioma. And the way how we know it's the endometrioma is because they get what you call a ground glass appearance. And usually that is significant in relation to endometriosis. And in this case, if you follow the arrow, this is the patient's womb right here. So usually you wouldn't find the cysts on the actual uterus itself. And the reason, and when you see this, then you know for sure that there's adhesions of the ovary onto the posterior wall of the womb. And
maybe I can ask a question here in terms of, because I do know some of our members of BAEP sometimes ask about ultrasound. So how effective are ultrasounds in diagnosing endometriosis? This is just for like a general public.
Ultrasounds will not pick up peritoneal disease, which is like if you put cling film on a piece of paper, it wouldn't pick that up because it's too minute. If you have like nodules, thick nodules and like your ligaments and stuff, it may pick it up. Or if you have the endometrioma, like in this picture, then if you have the endometrioma, definitely you will have endometriosis. So this is the ultrasound picture for this patient. And then when I subsequently did the laparoscopy, this is the bladder up front, which is empty. This is the womb here, and this is the endometrioma here. All right. Now, because when she has the endometrioma so high up and is attached onto the posterior uterine wall, more than likely there's a lot of bowel adhesions as well. So this is why we push the uterus forward, and all in here, if you see the arrow, all that is scar tissue involving the rectum, going all the way down into the pouch of Douglas, all right, which is the space between the uterus and the rectum itself.
So how did this patient present? Like, was she having lots of abdominal pain, even outside of her period?
Classically with constant abdominal pain, which gets worse with the menses, and also to pain while having sex, which is what we call deep dyspareunia, all right? So I'll show you the surgery after we completed it with her. Now, this isn't my picture, but this is a picture of a normal uterus. I haven't seen a normal uterus in ages. So this is a normal uterus. In terms of the next investigation will be a diagnostic laparoscopy. It is insufficient to diagnose a patient with endometriosis based on history alone, all right? Because at the end of the day, you're not doing the patient any favors. So the gold standard would be to do a diagnostic laparoscopy as a minimum. And if you do a diagnostic laparoscopy and you find endometriosis, then you have to surgically treat it depending on the skill level of the surgeon and the complexity of the case. So in this case, this lady, she had a previous treatment, excision and ablation 10 years ago. So she came to me recently with recurring endometriosis symptoms. So her main symptom was deep dyspareunia. And essentially what we do is go through the notes to see exactly what was done. And when we went back in, the picture was the same as the original surgery. So essentially all this here is fibrosis, and all this here is the new endometriosis. All right, these small vesicles. And you see it going from one side of the pelvis over to the other side. All right. And this is another case that was done. She was complaining of pain for 5 years. And if you see in the corner here, all that is endometriosis there. And the last lady here on the right, all these fine vesicles are on the, what we call the peritoneum of the pelvis. And these are on the pelvic side wall. And the risk for that is that it lies above all the vital structures. In this case, it was all over her ureter, which is the tube from the kidney to the bladder. Now,
Just got about 4 more minutes left on your talk, John. Okay.
No problem. So this one here shows the endometriosis on one of the great iliac vessels. And this lady came in with right-sided abdominal pain, and she had florid adhesions onto the bladder and the anterior uterine wall. Right, now, this lady here, she had an ultrasound scan, which was normal, but as you see, the uterus isn't bent over on itself, it's straight up. So one of the differential diagnoses is adhesions. So she had a previous cesarean section. So when we went in, she had a very thick abdominal adhesion onto the uterus. So this was laparoscopically excised. And the picture on our right shows the fallopian tube, which is caught up in a lot of adhesions as well. Now, sometimes you can get an MRI back, which shows that the patient has deep infiltrating endometriosis. And in this case, she had an MRI in 2018, but was only treated with contraceptives, which would not be appropriate management for her. And when we went in as part of a multidisciplinary team, this picture is what we found. So there's no anatomy here. So she's doing pretty well right now. She had a lot of dissection. Okay, now in terms of the management, I just want to talk quickly about surgical management. You must have a gynecologist with an interest in endometriosis. And in terms of complex cases, a multidisciplinary team. The advantages being that is evidence-based, you get better outcomes and you get better patient satisfaction and better patient experience, and you must have clear guidelines. The guidelines would be NICE guidelines, which is the National Institute of Clinical Excellence, the Royal College of Obstetricians and Gynecologists, and the guideline of the European Society of Embryology. And this is an infertility guideline. Now, in relation to the endometriosis team at my center, we have the patient in the middle. As you see there, the circles are different multidisciplinary team, and it ranges from the gynecologist to the laparoscopic surgeon, pain specialist, infertility specialist, the psychologist, which plays a major part, an adolescent pediatric gynecologist, a urologist, and a physiotherapist. Now, how does it work? It's the first time really a multidisciplinary approach to endometriosis from the start, and it usually involves the gynecologist, laparoscopic surgeon, and the psychologist initially, and is associated with better patient outcomes holistically, and you get good patient satisfaction. In terms of the psychological importance, what I from my practice, a close contact with a psychologist on the team is vital. Because you have a lot of anxiety and a lot of underlying issues prior to coming. You may need sessions prior to or after the surgery. Some patients have feelings of being let down and not listened to and fear. And we try to resolve these prior to surgery. So that's why I said thanks to Brenda, who is our psychologist, because she has a lot of work with endometriosis patients. Now, in relation to...
1 minute left.
Okay, no problem. In relation to laparoscopy versus laparotomy, laparoscopy is preferred because you get better recovery and better cosmesis. Now, in terms of grade A recommendations, if you find endometriosis, pelvic endometriosis identified at laparoscopy, then you treat it. It's not enough to say that you see it and then come out and tell the patient. We excise the endometriosis versus ablating it. The reason for that is that we remove everything. We send it for histology to actually confirm everything. This is another picture. Essentially, this is the one that I had showed you before. So this is before, and this is after everything has been excised. 4 weeks post-surgery, she doesn't have any pain at all. And this is the picture from before. So this is the adhesions coming up, and this is everything dissected out. And that's about four hours of surgery. This is an example of another endometrioma. She had a previous myomectomy and oophorectomy, and then had recurring bilateral endometriomas. So we went in and basically tried to clear everything up. So she had a good result as well. In terms of surgery, improves the pain and quality of life. And however, in terms of the complications, because of the risk of complications, then that's why a multidisciplinary team is important. And for fertility, laparoscopic surgery is associated with a better pregnancy outcome. If you find endometriosis at like laparoscopic sterilization, up to 45% of women have it and is asymptomatic. But the recommendation is not to do anything because they don't know the actual course of the disease. Now, in terms of referrals, it all depends on if the patients had or directly referred to or not, or if they have deep infiltrating endometriosis, or if they're of adolescent age, then in relation to the setup, it is particularly tailored for anyone. Now, the function of a multidisciplinary team is to review cases, plan optimum management, and to mitigate potential complications, and to review second look laparoscopies, which I've been doing a few, and to review any imaging like MRI. In conclusion, the endometriosis center is needed and present on the island. Is to streamline the care, it's evidence-based, patient-centered care, and most importantly, multidisciplinary care. Any questions?
Thank you so much for that very thorough presentation, Dr. Barker. I knew it was a lot for you to compress into just 10 minutes, but it was quite a bit of information, and we really do thank you. I know we're a bit pressed for time, so we might have to hold the questions until the very end, but just to let you know, there's one young lady here who is very excited to see you in clinic when she returns from, or you return, sorry, to St. Vincent. So we're going to move right along right now. Thank you very much again, Dr. Barker.
So we do wonder, having you heard your talk about multidisciplinary approach, about the role of other specialties, because we did talk about endometriosis being all over, potentially all over the body. So we have pelvic and we have outside the pelvis. We have, visceral, meaning attached to organs. We have parietal, meaning attached to the inside of the abdominal wall or the chest wall, etc. So now we're going to next hear from our gastroenterologist to figure out, how can endometriosis affect the gastrointestinal tract, and maybe how she can help. So we turn the mic next to Dr. Erica Springer.
Thanks very much. I'd like to thank the organizers for inviting me to take part in this discussion about endometriosis, more than a reproductive health issue. As has already been said, I am a gastroenterologist. That means I deal with the bowels, small intestine, stomach, and essentially the gastrointestinal tract, which does make you wonder what that has to do with endometriosis. Well, some of us may wonder that. So I'd like to start with some anatomy so that we all know what we're talking about. So like I said, I'm a gastroenterologist. The area that endometriosis typically affects, from my point of view, is the large intestine or the colon. So that's this bit here, outlined by the arrow. I like to think of the colon like a washing machine hose. So it's a hollow tube and it's folded up to fit inside the tummy or the abdomen. And your pelvis is this area a bit below the hip bones kind of thing. So what does the colon do? Just for context. So when you eat, food comes down into your stomach, into the small intestine where it's digested, and it arrives here in the colon as a wet slurry of undigested food and fluid. The function of the colon is to absorb water from that liquid. So the stool or the liquid stool moves from this part of the colon across the transverse colon and down the descending colon. And as it moves, water is absorbed from it. So by the time it gets here to the rectum, it's solid and is excreted then as solid stool. It really is plumbing. This is a side view now of the female anatomy. This is the thigh, just to orient you. This is the butt, and this is the front of the tummy. The structure that most people will probably recognize here is the uterus, which is where the fetus is housed for impregnant people. This is the ovary and the fallopian tube. So what does endometriosis have to do with the colon? Dr. Best already mentioned about there are several theories related to how endometriosis occurs in these extrapelvic sites. And one of them is this theory of retrograde menstruation, which is plausible from the GI point of view, but not really so much the gastroenterology point of view, but not so much for more distant involvement. So if you have a look here, this is the uterus. Behind that, so toward the back, is the rectum and the sigmoid colon, and toward the front is the bladder. So what they all have in common really is proximity or closeness to the uterus. And so one of the theories is that this is a front-on view now of the uterus, and this is the endometrial, this is the lining of the uterus, which is the endometrium. And this retrograde menstruation theory suggests that there is some backflow of blood at the time of the period. And because this area is open to the cavity, the theory is that it allows some deposition of endometrial-like tissue on various structures. And because the colon is nearby and the bladder is nearby, then that can occur. That is one of the theories. For appropriately placed endometrial tissue within the lining of the uterus, when the endometrium or lining of the uterus sheds, it exits the body through the vagina. For endometrial deposits in other places follow the same hormonal cycle as the uterine lining. So there is growth of the lining and shedding of the lining, but as was alluded to earlier, there's nowhere for that, there's nowhere for it to exit. So there is a repeated cycle of growth, shedding, growth, and shedding, which eventually leads to inflammation, irritation, pain, and scarring. I skipped a slide. I will say the most commonly involved intestinal organs in endometriosis, the data suggests, are the rectum and the sigmoid colon, which are pretty low in the pelvis here. So most of the cases of gastrointestinal involvement are rectum and sigmoid. Less commonly, the appendix may be affected. The appendix is this wiggly bit here that looks like a worm, and that's pretty low down in the abdomen as well. And part of the small bowel may be affected. So my slide says that.
Just keeping you up to date with the time.
Oh, sorry, I didn't hear what you said. How many more minutes? That's enough. Okay, so although in 96% of cases, the rectum and sigmoid colon are involved in the disease, gastrointestinal involvement is not that common. It is estimated that, as Dr. Barker said, between, well, the figures vary, let's say between 10 and 20% of people of ladies may have endometriosis. And only a small subset of those, maybe about 5%, may have gastrointestinal endometriosis. So what are the symptoms that you may have with intestinal involvement? It varies. The patient may have no symptoms, or they may have the more classical symptoms associated with endometriosis, such as painful periods, painful intercourse, and infertility, which is inability to have children. The symptoms a little bit depend on where is involved as well. A lot of the involvement, remember I mentioned that the colon is like a washing machine hose. So if we're looking on the inside of the hose, this is the wall. And then this is the inside part of the hose. And a lot of the involvement is on the outside part of the wall. So those patients may have a bit of pain when you press on their tummies. But depending on where exactly along the colon the deposits are, they may also have pain with passing stool. They may have constipation, bloating, and they may have bleeding from the bum as well. The severity of your symptoms don't necessarily correlate, however, with the severity of the involvement that is seen. So what's the role of the gastroenterologist? We're not particularly involved in treatment of patients with endometriosis. Our role mainly, well, we become involved if we see a patient that we suspect has it, and in that case, we refer to our gynecological colleagues. But the gynecologists also refer in the other direction when they are suspicious sometimes that there may be another component outside of endometriosis that is contributing to what is happening with the patient. So some of the things that can mimic endometriosis, as have already been mentioned, there are lots of things that can give abdominal pain in young women or even young men. So inflammatory bowel disease, that's a condition where the colon reacts against, your body reacts against your bowels. And so people might have tummy pain, they may have blood in the stool and diarrhea. Irritable bowel syndrome, very common, affects both sexes. And again, has features of tummy pain, alternating bowel habits as well. And then there are things like reflux and celiac disease. Celiac disease is a condition where the person is allergic to a component in wheat called gluten. And that, again, can cause bloating, tummy pain, diarrhea, and so on. These are the commoner conditions that we may be asked to assess for in patients who may not be responding to therapy or in patients, So the treatment, I have opted not to go into that as that is the purview of the gynecologist and the surgeon, but I thought I would mention that the treatment can be medical or surgical, and some patients also will do dietary and lifestyle changes as well in an attempt to manage their symptoms. the dietary and lifestyle changes often involve eliminating certain things from their diet, such as foods that they think might trigger their symptoms. So often patients will already not be taking gluten. They may not be taking red meat. They tend to avoid alcohol and caffeine and things like that. And I find here two things that have struck me. One is there is a lot of psychological distress, as Dr. Barker has alluded to, the fact that patients are having severe pain every month, and it does have an effect on your emotional and psychological health. In my practice, I have found patients are reluctant to get psychological help. So I think that's an important thing that Dr. Barker mentioned, that psychologist is an important part of the multidisciplinary team. And the other thing I would say is that we can't diagnose endometriosis if you don't tell us your symptoms. So many ladies that I see accept very painful periods as just being part of the norm. And I would like to encourage the members of the audience out there to consider seeing your GP or your gynecologist if you're having very painful periods, and because there may be something that can be done about it. So thanks very much for your time. I'll take any questions now.
Well said, Erica. And right at 12 minutes, so you had 3 minutes spare. You left us 3 minutes for questions, which is fantastic. Very understandable.
That I forgot
Sure.
to say. The reason we are not involved in the diagnosis of endometriosis, I guess I could go back here, often we're more of a ruling out other potential problems, is because, remember I said, we said the bowel is like a washing machine hose. When I do tests to look inside the colon, I can only see on the inside of that washing machine hose. I can't see what's happening on the wall, on the outside. And so if most of the deposits are on the outside, I can't see it. Occasionally we can, if they're on the inside and eroding in, and then we can take biopsies and send to the lab for testing. But our role is more from the point of view of assessing for contributing factors to abdominal pain in young women of reproductive age. Thanks.
Fantastic. I need to make an appointment. All right, so I'm not seeing any questions and answers in the Q&A box. Just remember, guys, that if you have any burning questions come up as the speakers are giving their dissertations, please put them in the question and answer chat. We can pose them to your speakers as we go along. You can also put things in the chat box if you so desire. Any questions for Dr. Springer-Cyrus from our co-host, Rashida, or from any of our other panelists?
I actually do have a question. I wanted to know, in terms of perhaps a misdiagnosis, how many or what percentage of your patients you think might present to you thinking that they might have inflammatory bowel disease and actually end up having endo? I recently had a patient who came in to our practice, and she was having this kind of cyclical pain. She was saying initially it was in her chest, and when she went to her GP at that time, they just, I think, sent her away with some medication, but it just didn't get any better. And I would have sent her for an ultrasound, which showed that her bowel was actually, the bowel wall was very thickened. We were kind of not sure whether it was inflammatory versus endometriosis. So I just want to know in terms of the presentation to you per se.
I don't see many patients with endometriosis to my practice as a presenting complaint. I do have a few patients, but not many, that I have referred to the gynecologist with that as a suspicion. But their symptoms are often quite classical, which is the cyclical abdominal pain, and sometimes really all it takes is the history. And the reason I actually started with the anatomy is that it is difficult sometimes to see where this pain is localized, because in the Caribbean, your stomach is anywhere from your chin to your groin. And so, you know, I find that getting a really good idea of where the pain is and the triggers are sometimes, you know, all it takes. And sometimes the ladies themselves have not made the association. So, you know, while you're talking to them, then they might say, yeah, it's there all the time, but then over my period, it's really bad, you know, and they tell you the story. Bowel wall thickening can be seen with inflammatory bowel disease, yes. And so I'm not sure if your patient has been investigated or not. It would depend. If she's having cyclical pain, her first stop might be the gynecologist, but we would investigate for inflammatory bowel disease, because she would be in an age group where this would be something that one would see as well.
That's actually referred to Amy, as normal gynae, and the surgeons kind of touched on our thing. But she was in very severe pain. I wasn't able to get her controlled, so I had to refer her.
Right.
Yeah. So our 15-minute window is unfortunately closing. But yeah, a quick question from me. How likely are we to have, with vomiting every menstrual cycle, endometriosis?
It is, as you know, it is discussed as one of the I guess mechanisms, or one of the presentations of endometriosis. I have seen that only in one patient with endometriosis, and in that patient, it was not entirely clear to me whether it was endometriosis or if she was having catamenial migraine with vomiting. Catamenial just meaning at the time of the menses, because that's when her vomiting would really, she would have, at the time of her period, she would have abdominal pain, also though migraine type headache and vomiting. So I can't say that is something that I have seen much of.
Thank you. That helps me a lot. All right. So if I don't see any other questions in the chat or the Q&A, so in that case, I will take the time to thank Dr. Springer again for a wonderful talk. And of course, you need to stick around for the panel discussion at the end.
It was my pleasure.
Thank you so much. So we'll pass it to Rashida to introduce our next speaker, who should be Dr. Sati Persaud.
Next is Dr. Persaud. So we're just going to ask Joe to put out his presentation. So I'm actually very excited for this presentation as well, because a lot of our members within the association do report symptoms in terms of urological symptoms. So I'll hand over to you, Dr. Persaud.
Mute. Sorry, I was muted. I just want to thank you guys for letting me speak tonight. Thank Rashida, Julia, and the team for an organization that's really making a difference and is very, very professionally run. I mean, I was very impressed in the run-up leading up to this, just keeping in contact and making sure everything, all the housekeeping is taken care of. So it's a pleasure to be here tonight. It's very appropriate the way the order in which they put it. John first, then Dr. Springer, and then myself, because that's probably how it goes in terms of frequency. You have the GI system next after the female reproductive tract. And the most common, second most common system affected is the urinary tract. And various theories abound, as Damien was Dr. Bark, Dr. Best was alluding to earlier. There are a number of theories. The simplest one is reflux. So just refluxes up the fallopian tubes and then implants elsewhere. There's direct extension, so what they call adenomyosis, that might come out of the uterus and becomes implanted into the bladder. There's, you know, it's funny that you can have endometriosis in men. It's usually in men who are being treated with estrogens for prostate cancer, or people with liver failure who have a high, or obesity, men who are obese and have a high. When you're obese, you literally convert, your body produces a lot of estrogen in the fat, and that can lead to endometriosis. I mean, this is very rare, but we think that might be due to what Dr. Best was referring to as the embryonic remnants, the Mullerian remnants that are supposed to regress as a fetus develops from into a boy. That's supposed to regress, but sometimes a little bit hangs around and you end up with different stimuli, end up forming endometriomas. It's very, very rare. I mean, these are case reports we're talking about, but it does happen. And even with Mullerian agenesis, where a woman doesn't have a uterus, they've been known to form endometrioma. So this is is a disease that we really don't know as much about as we should. So that brought rise to the influence of immunologic influences, as well as what they call coelomic metaplasia, where as Dr. Barker was saying, the peritoneal lining, bits of the peritoneal lining turn into, essentially, you have different stimuli, and we don't quite know what, and they can turn into material that looks like the endometrial lining. So there are multiple different theories, and I suspect it's a little bit of everything. Now, within the urinary tract, and I put this here for you to see the urinary tract, and we have the kidneys. Let me set my pointer up. We have the kidneys here coming down into ureters, then it goes into the bladder. And then after the bladder, coming out of the body is the urethra. So this is the ureter, U-R-E-T-E-R, and this is the urethra at the bottom here. And the most common area of involvement for endometriosis in the urinary tract is actually in the bladder with 85%. And then we have the ureter after that. It's very rare to see the kidneys involved or the urethra. And the prevalence varies widely. The data suggests between 0.3 to 12%, and I suspect it's actually towards the lower end of this number rather than the higher end, because I mean, even as urologists, we see thousands of patients every month, and it's very rare. Part of that is because of awareness, I guess, and part of that is just the natural disease that it tends to affect the urinary tract uncommonly. Now, cyclical hematuria, what they call catamenial hematuria. Hematuria simply means blood in the urine. Is almost pathognomonic for endometriosis. So I've had patients who come and again, as Dr. Springer was saying, nobody listens anymore. I mean, you talk to these ladies and every month. So when are you bleeding? It's like every month, doc, for the last 6 months. So, is it a particular time? Is there a wrong period? Yes, it's a wrong period. And it's almost pathognomonic for vesicle, meaning bladder endometriosis. But you can also have urgency, which is like a urge to go to the bathroom that you can't put off. Frequency, which is going by definition more than 8 times per day. Suprapubic just means just below the area below the belly button there. And dyspareunia, which Dr. Barker was talking about, meaning painful intercourse. Now, Dr. Barker went through diagnosis, and there are a number of history and physical examination are key, but there are a number of modalities that are available to us. Ultrasound, CT scans, MRI is actually quite good. And as he said, diagnostic laparoscopy is important. Now, it's also important to stress that you can have no symptoms, no urinary tract symptoms, but still have urinary tract involvement. So the person might go for diagnostic laparoscopy and see the endometrioma in the bladder, or they might have some other symptoms, some GI upset or something, or a little bit of pain, and they go for an ultrasound and they see swelling in the kidney, where the endometriosis has affected the tube that's leading from the kidney and cause upstream swelling.
For the benefit of
here is an ultrasound. This is.
Oh, sorry, Sati, didn't mean to cut you. I was just saying that for the benefit of the audience who might be familiar with the ultrasound, as Dr. Barker mentioned it, and laparoscopy, he did mention as well. Can you tell us a bit more about what a CT is, what an MRI is, and how well those things image endometriosis? Yeah.
So the CT scans and the MRI are less operator dependent, meaning if you have a bad ultrasonography, you're gonna have a bad image with the ultrasound, right? Not to disparage anyone, but the CT is more objective. So it is a computed axial tomography, and it's like a fancy X-ray, and oftentimes they give you contrast. So they give you a dye through the veins, and the dye kind of highlights the arteries. And if you leave it long enough, the dye will highlight the kidneys as they're producing urine. So the dye, everywhere that's producing urine, the dye highlights the areas, and you can actually see the kidneys outlined, and you can see the tubes going all the way down into the bladder, and you can even see the bladder as well. So it really gives you a good overview of the entire urinary tract. And the same thing with the MRI. You can do it with or without the dye. It's a different type of dye, but you can do it with or without the dye. But these are very good tests for looking at the urinary tract because they give you such detailed images. The disadvantage with the MRI is it takes a little bit longer, and some people are claustrophobic and they don't want to go into the machine, but they are open MRI scanners now. No, this is not, the top image here is not mine, I must admit. This is an image here, a CT scan of a endometrioma is actually projecting into the bladder. So this, where the arrow is the endometrioma, and this is very striking. This is not typical at all. It's a very striking example. This is the bladder here, and this is the endometrioma here. This patient here was actually one of my patients that presented just a classical catamenial bleeding, meaning she had hematuria every time she had her period. And whenever urologists get hematuria, we do two things, a CT scan and a cystoscopy, which is a minor procedure done in the office. Takes about 5 minutes with a small camera, and it's not as scary as it sounds. The camera is about as thick as a pen, one of those paper-made pens, or even thinner, and you pass it under local anesthetic into the bladder. And we actually saw this. So this is why I took a. If you see it at the right time, you can even take a biopsy of it and take it to the lab, and they will see what looks like glands from the endometrium where it's not supposed to be. Oh, this is a CT scan, and this is what I was telling you, you get detailed pictures. You will not see this on ultrasound.
Before you move, there's actually a question here related to the CT. A patient is asking at what point would a doctor send a patient suspected of endometriosis to do a CT scan?
I suspect it really depends on the patient and what symptoms they're having. Certainly if they're having hematuria, if you see blood in the urine, the CT scan with the delayed phase, so not just a regular CT scan, you need to give contrast, and you need to give that contrast about 10 minutes. What happens after 10 minutes, it becomes excreted into the urine, and you can actually see the outline of the kidneys and the ureter. So you would actually see this. This is the tube coming down from the ureter, coming down from the kidney. So the kidney would be somewhere here. The tube would be coming down, 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 and this is the bladder here. All right, this is the uterus, and you can see here, right out here where this arrow is, you can see endometriosis causing a narrowing in the tube. This tube should probably not be this wide. So to answer the question, it really depends on the patient. If the patient is having hematuria, or if they're having a pain that they couldn't identify, they might end up having a CT scan. There are no specific rules on when to send the patient. A lot of it depends on judgment and presenting symptoms. So this is an example here of endometriosis, endometrioma or endometriosis lesion blocking off the ureter, and this can happen. And if you were to take it, so this would be if it was along this tube here coming from the kidney down to the bladder. And if you were to take it out and send it to the lab, this is what you would see. This is normal ureter here. This is how it should look. And you have this abnormal infiltration. So imagine you have uterine tissue where it shouldn't be, in the ureter. Now,
you're at 5 minutes. 5 minutes
really the
remaining.
domain for Dr. Barker.
5 minutes remaining.
Yeah, that's more than enough. All right, thank you very much. And the treatment is not cookie cutter at all. It's really individualized according to the patient. So you really have to sit down with that woman and decide what her priorities are, what she wants, how bothered, what her level of bother is, where she is with her life. Because you can have medical and surgical treatment. You can start with medical treatment and see how they respond before you go to surgery. Some things require surgical treatment up front. Obviously surgical treatment comes with potential complications. And by medical treatment, I mean the oral contraceptive pill, or there are different injections. There are progesterone injections you can give, or there's this is just one example. This is just one brand name. Zoladex, which is goserelin. And what it does is you give an injection every 3 months, and it actually shuts off production of the hormones in the head centrally. So it cuts the menstruation, and you find that the symptoms tend to abate. But the oral contraceptive pill is another option, but that's really the gynecologist. How we get involved is when you start to get involvement into the bladder and they get bleeding with the periods and it's really bothersome, or the endometrial, the lesion blocks off the tubes coming from the kidney, and we're worried that the kidney is going to fail, or anything that's causing severe pain and touching one of the urinary tract organs. And again, the treatment is individualized, and it really depends on the location where the lesion is. The surgery can be open or by keyhole, depending on the level of skill of the surgeon and how complex the lesion is. And why I put here that why the removal tends to do better. If you have a lesion in the, and by lesion, I mean like a endometrioma in the bladder. If you resect, if you cut out that lesion and there's an area adjacent on the uterus there that you can remove that as well, they tend to do better than if you just cut out the area on the bladder alone. And certain areas in the bladder, when we're treating it, tend to do better. So for instance, the dome of the bladder, where you can actually remove, just take a wedge of bladder out and close it back and remove that endometrial tissue altogether, they tend to do better. Now, I just put this in here.
Describe the dome so that the audience can picture it. They might not know.
So the dome?
Yes.
So the dome is somewhere up here, rather than the base of the bladder that's under here. It's easy to reach through the abdomen. And you can imagine if a lesion is under here, it's very difficult to remove the entire thing. Whereas if it's up here, you can just take a wedge of that out and close the bladder back, and you get a very good outcome.
So what sort of symptoms does that cause? I do have a patient who has a lot of bladder symptoms. I do think she gets a lot of dysuria and stuff. So I guess it depends on where it's located. If there's endometriosis there.
It does. Yeah, it does. And in the trigon, I would imagine gives you more symptoms.
We're at 2 minutes, by the way. Sorry about that.
No, that's fine. It'll probably give you more symptoms if it's in the base of the bladder, probably. But you can get urgency, frequency, bleeding in the urine. And if you really want to see it, when they're having the period, it's probably a good time to do a cystoscopy. So this is a robotic operation. Let's put this up here to give you an idea how difficult this surgery can be. If there's an endometrioma causing obstruction in the ureter, which is the tube coming from the kidney to the bladder, the scar tissue there can be significant. As Dr. Barker, I'm sure, has probably had nightmares about this already. You know, you see the ureter somewhere in there in all the scar tissue. And what they've done is, and you have nerves running behind it, nerves running, next to it. And what they've done is they've tried to, what they call ureterolysis, where they actually remove the scar tissue from over the ureter. And I've seen people try to do this and poke holes in the ureter, and then we've got to go and fix it. Luckily, we can just put a tube in and just keep it for a few weeks, and the ureter usually heals itself. But this is by no means easy surgery. And as Dr. Barker quite rightly said, multidisciplinary approach is key. Now, sometimes when we have a lesion down in the close to the bladder, we might not bother with ureterolysis altogether. It might be better to just take the ureter out of the bladder altogether and plug it into a different location in the bladder. That's called ureteral reimplantation. Or sometimes we cut a segment out of the ureter and just join the ureter back together. You know, so I just put these slides up to show you how extensive this can actually affect someone. If it's causing kidney failure or the kidney to become damaged because it's obstructed, we might just need to cut that entire area out altogether and just plumb it back into the bladder. So no two patients are exactly alike. And this can be quite difficult surgery, and multidisciplinary approach is the key. So I think that's the end of it for me. I know there's a lot to unpack, so I try to keep it as simple as I could.
That was fantastic, Sati. I enjoyed that. So especially this picture here where you're reimplanting your ureter into bladders elsewhere. That's pretty neat. Now, we do have a question in the Q&A for you as urologists. Is it necessary to take out an endometrioma on the bladder if it's not causing symptoms? That's a part one.
Right, and then does it have to be a gynecology? Yeah, I see it. Yeah, I mean, it all depends on that patient, right? I mean, if the lady's fit and is not causing any symptoms and just incidental, then that's something to discuss with you merits a surgery with your urologist. But I probably wouldn't if it's not causing any symptoms, you know, and especially depending on age as well. Depending on age, if she's, you know, young person with a whole life of endometriosis ahead of them. So no answer is right or wrong. It really warrants the discussion. But I would say if it's not causing any symptoms, I certainly wouldn't recommend surgery. Just, you know, with the information that I was given. It ideally should involve a gynecologist. I tell people I'm not a hero, and I certainly wouldn't go tackling these things without involving one of my colleagues. Right? You know, it doesn't have to be a formal multidisciplinary team. I mean, certainly you can find a gynecologist. There must be in Canada. You can find a gynecologist and a urologist willing to work together.
Yeah. So, I mean, I'll give an anecdote. I did find a patient was referred to me as a fibroid indenting the bladder. And on a transvaginal scan, this was a clear something in the wall of the bladder, and I couldn't figure out why the urologist didn't want to take the patient. So I did get a second opinion, and the urologist did operate on that lady to take out her bad endometriosis, but that was definitely causing her some cyclical symptoms. So she was bleeding every month through urine, and she was having some pain and stuff. And that was the only site of endometriosis. So in fact, the urologist did the surgery solo, didn't need us. So for that attendee, it would seem as though while it should ideally be a multidisciplinary approach, sometimes if it is something that's particularly urological that the gynecologist isn't a lot of help, it might be that it falls under one category or the other. So gynecological issue or urologist issue. But certainly we do interface with each other.
Yep.
We do interface
somebody
with each
should
other.
Probably. Sorry, go ahead, Damien. I'm sorry.
Yeah, I say we do interface with each other if we're clear that the problem probably involves both systems.
Yeah, but somebody can take the lead.
Absolutely.
Somebody can take the lead.
Right. So, I mean, some papers I read in preparation for this, I've seen some talk about visceral endometriosis affecting the kidneys. Have you ever seen or heard of that one?
No, I've heard of it, but I mean, it's 4% of all urinary tract endometriosis. I've certainly not seen in my doing urology now for 10 years. I have not seen anybody with kidney endometriosis, but you just kind of wonder of those renal cysts that you do see, how many of them, what percentage would actually turn out to be endometrium if you were actually supposed to look at all of them, because cysts are very common. So it's 1 in 4 persons has a cyst. So one, probably 2 or 3, 2 of us on this panel have kidney cysts. So, and they're often just fun facts.
Might be me.
Yeah. Knowing my luck, it's probably me.
Right.
So,
thank you again,
yeah.
Sati. We're looking at the Q&A. We have another kind of looking gastroenterological / surgical maybe question. We don't have any others for Sati at the moment, unless any of the other panelists want to ask Sati a question. Any questions for Sati, Sally? Erica?
Yes, I have a question.
Yeah.
And this is because I am not a urologist. But in inflammatory bowel disease and Crohn's disease, when patients have resections of the colon, there is a risk of new disease forming at the joint between the new joint where you've taken out. Is that a possibility when you reimplant ureters and things like that? Or is that very rare?
Is always a possibility. Even when you resect it, there's always a possibility that this thing comes back. I mean, it depends on whose data you're looking at and how honest they are with the reporting. But I suspect it's probably up to a third will get some form of recurrence. And sometimes you need to combine surgery with hormonal treatment. I don't have data on reimplantation specifically because it's so rare. But I would imagine that that's a possibility.
Thank you.